morning. It's really an honor to be here today. I'd like to thank the committee for the invitation to present. And it's really a delight to see so many familiar faces, and as well as the opportunity to meet people who I have really looked up to for many years. I understand the committee has heard prior presentations on POLST and is familiar with the model, so I am really going to just jump into talking about some of the evidence about use of the POLST paradigm. I will say my goals today include addressing the specific questions raised by the committee regarding the impact of the POLST on clinical outcomes. I'm not going to be able to address every single research study that's been done on POLST. There have been about 15. I really decided to focus in on the ones I thought were most relevant to the questions posed by the committee. I'm going to talk about some of the limitations of existing research, some of the gaps in our knowledge, as well as propose some directions for future research in this area and policy change. The evidence is very clear that the use of the POLST helps ensure individualized patient-centered care. When we have POLST, we have the opportunity to create a plan of care that reflects an individual's goals rather than an all-or-nothing approach that code status typically offers. We know from several studies that when an individual has a POLST form and it has a DNR order on it, that this is not indicative of preferences for other kinds of treatments. We see lots of individual variation. And actually in a recently published study by Bud Hammis of the La Crosse community, they looked at 400 decedents and looked at their medical records and found that out of 36 clinically feasible POLST form combinations, they found 35 in that population or that sample of just 400. So again, it really is used in very unique ways depending on the individual to individualize care for that patient. Additionally, when we have POLST forms, we have way more information about treatment preferences and way more information in the record about that individual's plan of care. These plans represent preferences for the immediate present, not plans for some future. It's not if I'm close to death, it's right now, this is what the plan of care is. In 2006 and 2007, we conducted a multi-state R01 funded by the National Institute of Nursing Research, in which we selected a stratified random sample of 90 nursing facilities in Oregon, Wisconsin, and West Virginia, and we did chart reviews in all of those facilities. And we really purposefully stratified our sample by high POLST using facilities and low POLST using facilities. And what we found was that residents with POLST forms had significantly more orders in their chart about their preferences. Obviously, with resuscitation, we had fairly high rates among the non-POLST users, but even that was a significant difference between those two populations. POLST users had significantly more orders about resuscitation preferences than those without, which is really remarkable when you consider this was primarily a long-stay population. The average length of stay was about 3 years. When you exclude resuscitation, you see even more dramatic differences between the groups of POLST and non-POLST users. 98% of POLST users had orders about preferences other than resuscitation, compared to just 16% of residents without a POLST form. Now this slide is a little bit overwhelming, so I'm going to help orient you. It's really just simply information about POLST form orders from 5 different studies that I've lined up based on their categories. And if you look at code status, which is in the very first column of data on your left, you'll see that I've lined it up based on the percentage of DNR orders within the population. And really, the overall message of this slide is fairly straightforward, that the orders that any individual patient has are going to vary depending on the setting and depending on what population that patient belongs to. So in the hospice sample and the community-based decedent sample, the vast majority of individuals with POLST forms had orders for DNR. When you look at the bottom, you see the Oregon Registry sample, which is a much broader, more community-based sample, including many people who live independently in the community, and in that population, just 72% had orders about DNR. In the nursing home setting, you see about 86, 88%. We also know from the multi-state R01 that there are other factors within that population that differentiate what kinds of orders patients have in that setting. Individuals near the end of life tend to have orders for less aggressive interventions. We also know that there are racial differences, that non-white patients tend to have orders for more aggressive interventions than white patients in those populations. There also is a possibility that POLST orders vary by state as well. So this is data that's actually unpublished from the R01. in which it lays out the orders based on the state involved in the study. And as you can see, when you look at the Section B orders, patients in West Virginia had significantly more orders for limited additional interventions or full treatment than they did in Oregon and Wisconsin. Now, this is descriptive data. It does not control for covariates. We know there are some significant covariates in this sample. It also, does raise questions, though, about other factors that might be driving the way in which the POLST form is used. And I think it's important to keep in mind that just introducing POLST into a state doesn't automatically make every state look the same or create similarities in the levels of treatments across those settings. Clinicians' reports about their experiences using POLST are overall highly positive. In a hospice sample, we talked with hospice personnel in Oregon, Wisconsin, and West Virginia, and a majority felt that it was helpful in guiding treatment and initiating conversations and providing clear instructions about what to do. We also have information from clinicians about their experiences working with the POLST form. Two different studies focusing on emergency medical responders have found that they report it frequently changes the plan of care. Most recently, the Oregon team did a follow-back study from the registry of calls that had come in. They went back and touched base with the emergency medical responders and found that POLST altered decisions to transport that patient in 26% of cases. Now, it's a pretty small sample, but I think, again, it's suggesting that from the clinician's perspective, this is providing information that does alter the plan of care and that is valuable. Several studies have looked at the association between POLST form orders and the treatments that people receive. And I think the most rigorous study, which is the one I'm going to focus on, is the multi-state R01, which I conducted with my colleagues, Dr. Susan Toll, Dr. Woody Moss, and Dr. Bud Hammis. What we found, one of the things I think makes this data actually some of the strongest is we have a comparison group. We can actually look at a similar group of residents who don't use POLST forms, not because they're the only person in a nursing facility out of 200 people who don't have a POLST form, but because their facility just hasn't embraced this as a practice change for whatever reason. And this data actually reflects a sample of 1,606, and that actually enabled us to do multi-level modeling. So we were able to control for covariates that influence the kinds of treatments that people receive, things like whether or not they're near the end of life, whether or not they're on hospice, whether or not they're white or non-white. And actually, we also were able to control for facility-level characteristics as well using multi-level modeling. So we eliminate the possibility that in one facility there's a practice pattern because of the medical director in charge of that facility. And what we found was that overall, residents without POLST forms received significantly more medical interventions during our 60-day review period than residents with POLST forms. But the residents with POLST forms were not all the same. When you look specifically at the kinds of orders that are documented, treatments were associated with orders. So residents with POLST Comfort Care orders receive significantly fewer treatments than residents with POLST full treatment orders, and this is in Section B of the form, which deals with medical interventions. I also will note that the top two lines look like they might be far apart, but when you take into account the covariates, there's no statistically significant difference between residents with POLST full treatment orders and residents without a POLST form at all. Actually, I'll also say despite those differences in treatments, we found no differences in reports of pain or shortness of breath or the treatment of pain or shortness of breath. So we're not seeing that these residents in the POLST Comfort Care are experiencing distressing symptoms, at least not the symptoms that we were able to easily identify within their records. We also know that the treatments provided were highly consistent with the POLST orders. Overall, 94% of the treatments provided were consistent. Now, Section A is the only section of the POLST form that allows us to make a determination about whether or not a treatment was indicated and not provided or indicated and provided based on the order available. Because we know if someone has died, that resuscitation is theoretically indicated. You can certainly think of examples where that might not be true. If somebody is found cold and stiff or starting to become stiff, that obviously would be a counterindication. But overall, we were able we found that overall 98% of the time with resuscitation orders that orders for either DNR or full treatment were honored in that population. The 6 discrepancies were all individuals who had orders for full code who, for whatever reason, resuscitation was not attempted. In sections B and D, we can really only look at whether a treatment that was provided was consistent with the orders. So again, if a treatment, if there's an order in place for comfort care and the person never went to the hospital, if we don't have any information about whether or not hospitalization is indicated, we can't claim that POLST is responsible for them avoiding hospitalization. So I really want to put that idea in your head that part of the challenge with some of this is determining whether or not an intervention is indicated. Often people don't document decisions not to do things. In terms of the overall percentages, obviously there's fairly high consistency both for medical interventions and antibiotics, less for feeding tubes. Those discrepancies that we did find were largely people who had orders for limited treatments with a supposed time frame, and they were individuals who either there was no time frame documented or they had the feeding tube in for more than 30 days, which is sort of the recommended trial period in the POLST educational literature. Now, there were no differences between POLST orders to provide or limit antibiotics and standard care, so we found fairly similar usage rates of antibiotics across all those populations. And as a result, some states have actually removed antibiotics as a separate treatment category from the POLST form. They folded it into Section B. I don't personally fully agree with that, but I understand why people have done that. My concern is that it sort of narrows the individualization of the orders, and when we looked at the data, there certainly were many people who wanted antibiotics who also wanted comfort care, and those two would be inconsistent to have antibiotics for curative treatment and also be comfort care. We also were unable to analyze the data about resuscitation or feeding tubes using our multi-level modeling. We had far too few events in order to do the multi-level modeling. And the committee specifically raised the question about the use of CPR, and we simply don't have the data to address that question at this point in time. We really would need a much larger sample to make a determination about whether POLST actually prevents unwanted cardiopulmonary resuscitation. In the nursing home setting, other research suggests that by and large, resuscitation is fairly uncommon in that population anyway. So I think, again, we're talking large numbers to try and identify the effect. Now, the data about whether or not POLST represents patient preferences is weaker, and we have some indirect evidence. For example, in that lacrosse follow-up study, there was evidence of informed consent about the POLST form in 94% of the medical records of people who died with the POLST form in place, so that suggests that there's been a conversation. Those conversations were largely with surrogates and not with the patients. We also know that hospice staff express a lot of confidence that POLST is representative of patient preferences. And we have 2 smaller studies that actually provide some data comparing what's on the POLST form with a conversation with that resident or family about what the preferences actually are. In the study done in Washington, they found that POLST accurately conveyed treatment preferences 90% of the time, which sounds great until you really read the methods section of that paper and realize they're talking about 7 cases. Additionally, I have a study that was just accepted with minor revisions in the Journal of Palliative Medicine, in which we followed patients at the time of discharge from the hospital to the nursing home and then interviewed them in the nursing home about the POLST form orders. And we found that overall that their recall of decisions about preferences were 72% of the time consistent with the POLST form orders. Most of the inconsistencies were actually in the direction of overtreatment. The POLST reflected full code orders when they actually wanted some limitations. And those were POLST forms that were generated in the hospital at the time of discharge. The committee also specifically raised the question of whether POLST affects ICU care in the last week of life. And this is a great question. You could certainly extrapolate that. We know that residents with comfort care only orders go to the hospital less frequently based on our R01 data, so you could assume if you're not going to the hospital, you're not going to the ICU. But really, we don't have any data specifically about this because the incidence of ICU stays in our large multi-state study was actually very low, both in the POLST and non-POLST using samples. We just really couldn't do that analysis. We did attempt to connect our information about the rates of use of POLST in the nursing facilities around each of the states. We attempted to connect that with the MDS data, but we ended up feeling that our usage data was really not solid enough to do those analyses. So we looked at both Dartmouth data and MDS data and ended up deciding it was meaningless because we were not confident about the reports of usage from those facilities. It was good enough, solid enough to sample based, using their reports, but not solid enough to actually base a whole analysis on. I also pulled some data from the Dartmouth Atlas, which has a wonderfully fun website you could spend all day doing all sorts of analyses with. And I went back to 1996 with this data about the percent of decedents admitted to the ICU during the hospitalization in which death occurred. And you can see that Oregon is the triangle, the blue triangle at the bottom. And 1996 is about when the POLST program began. And what this suggests to me is Oregon has always been on the low end. The national average is a sort of olive green line with a star through it. And Oregon has always been below. They've always trended below. Interestingly, Wisconsin, I've mapped on there as well. They've got the blue diamonds. Wisconsin has always been low. And what's particularly interesting about that is in Wisconsin, POLST use is only regional. They started using POLST in full force in that community in about 2000. But we're talking about a state where the overall context is low rates of this aggressive intervention. And in contrast, West Virginia, which is a mature POLST using state, they've been using POLST statewide for many years. They're indicated with the blue box up at the top, and they have always sort of trended at or above the national average on this specific indicator. And then I added Indiana because I'm from Indiana. So, just as a comparison for a non-POLST using state. So I'm not sure this really tells us about the effect of POLST. I think there are way too many variables that we can't take into account by looking at the Dartmouth Atlas data. I think it raises a lot of interesting questions. I know Joan Tino has recently published a really interesting study about increase in use of ICU care in the last week of life. And it may be that there are differences in the increase in these states that use POLST. It's really unclear. But I think it's challenging to answer those questions without data about what's actually happening at the ground level. What percentage of facilities are using POLST? And not only are they using it, but how is it being used? I have already mentioned several limitations of the existing research, but I'm going to call out a few more. Most of the research currently is from Oregon and Wisconsin. These are places where there have been intensive efforts to implement in those communities. They are largely white and homogeneous. And I think it raises some questions about how generalizable some of the findings are. Even the multi-state study, which was Oregon, Wisconsin, and West Virginia, those are all actually three very white states. And we had to oversample in order to achieve a 12% racial and ethnic minority. It took quite a bit of work to get that. We also have a reliance on correlational and descriptive data, which is a really great place to start a program of research, and I think sometimes it's really the best way to answer a question, but I think we also need to move beyond that and start looking at comparison groups, thinking about match controls. And then finally, I think although the evidence that we have currently is really supportive of the POLST model overall, there are still many unanswered questions or imperfectly answered questions that need further attention. So I wanted to conclude with some directions both for future research and also suggestions for policy change, since this committee is, I know, particularly interested in that. So one of the areas I think is especially interesting is this idea of the quality of decision making. Are the decisions reflected on POLST based on informed decisions? Are they consistent with patient preferences? These are really important questions. If we know it's something that changes care, is it changing care in a way that matches what people want? We also need the development and testing of educational interventions that are evidence-based, decision support tools, and I know Rebecca Story will be talking more about that. The one model that is used most widely at this point is the Respecting Choices POLST facilitation model, but that actual component of Respecting Choices hasn't been tested. The next steps, which are disease-specific advanced care planning, has been. I think we also need more research that's population-based with match controls. We need to really start thinking broadly about what kinds of confounds could be influencing how the POLST is used and how it's working in different communities. And then I think we really need to better understand the patient and family experience with POLST. What do they think it means? How do they feel about making these decisions in advance? Is there decision regret? The committee specifically asked about that. No one has looked at that to my knowledge. What is their level of satisfaction? And then what is the impact on bereavement outcomes, which I think is a really critical question. In terms of policy, I think there needs to be increased incentives for advanced care planning, including POLST conversations. I think it's way too easy for for the POLST to be treated like a checklist. It really should be about the conversation, but right now we don't have a system that really incentivizes organizations to invest in education, in time, in people who have those skills to hold these conversations. We also, need to question. I'm really puzzled and a little frustrated, well, I'm sure there are good reasons, about the removal of all of the advanced care planning indicators from the minimum data set in the revised version. I think the biggest concern I have from a research perspective, it's a loss, but from a practical standpoint, it really is what tells nursing facilities what's important. It's really a motivator for them in terms of where they place their priority in the care they provide. So I think the absence of that is a challenge. I think we also need to think about broadening an access, upstreaming access to palliative care to introduce targeted advanced care planning in patients with serious illness earlier in the disease process. We are not going to be able to rely on just specially trained palliative care specialists because of the limitations of that workforce, but we need to start thinking about who else can develop expertise specifically in these kinds of conversations so we can start offering this to a broader range of patients. And then finally, I think we really need to think about the inclusion of advanced care planning and POLST specifically in electronic medical records. I will note that less than half of the long-term care facilities in this country actually have electronic medical records, and they are one of the largest users of POLST. So there are some challenges with even this recommendation, but I think it makes me wonder, why aren't there incentives for nursing facilities to adopt electronic medical records? There are a couple of good products on the market, and I think if we could start having a better communication between all of the healthcare settings that care for frail elderly patients, I think we would see better outcomes overall, because a lot of the challenges lie in poor transition communication. I think the final piece of that is, I know several states have developed registries, which I applaud the work that's gone into those, but I think we need to have this really as an integral part of the records rather than a separate standalone resource or facility for forms so that people can better access them. So thank you very much again for the opportunity to present, and I'm going to conclude here and hope I haven't gone dramatically over my time and turn the floor over to Rebecca. Thank you.